Welcome to This Week in Pulmonary. This week we are covering 8 notable papers spanning non-invasive respiratory support, risk prediction in pulmonary diseases, and precision approaches to chronic airway inflammation. Let's dive in. We begin with a major clinical practice guideline from the American Thoracic Society, which addresses the use of non-invasive respiratory support in adult patients with acute respiratory failure. To resolve long-standing uncertainty regarding optimal patient and modality selection, a multidisciplinary panel conducted a comprehensive review of high-flow nasal cannula, non-invasive ventilation, and continuous positive airway pressure. For patients with acute hypoxemic respiratory failure, the panel issued a strong recommendation for high-flow nasal cannula and a conditional recommendation for non-invasive ventilation or continuous positive airway pressure, emphasizing the need for close monitoring and prompt escalation if intubation becomes necessary. In contrast, for acute hypercapnic respiratory failure, the panel made a strong recommendation for non-invasive ventilation to reduce mortality and the need for invasive mechanical ventilation. High-flow nasal cannula received only a conditional recommendation in hypercapnic patients, restricted to those with less severe hypercapnia and mild acidemia, defined as a pH greater than 7.25, and only if close monitoring and rapid escalation to non-invasive ventilation are readily available. The guideline also provides strong recommendations for using either high-flow nasal cannula or non-invasive ventilation for pre-oxygenation prior to endotracheal intubation to prevent peri-intubation hypoxemia. Finally, for post-extubation care, the panel suggests a risk-based strategy: high-flow nasal cannula for low-risk patients and non-invasive ventilation for high-risk patients to minimize the risk of re-intubation. This guideline provides a highly practical, standardized framework that clinicians can immediately implement at the bedside, balancing patient risk, interface tolerance, and institutional capacity. Next, we turn to advancing our prognostic capabilities in chronic pulmonary conditions, starting with obstructive sleep apnea. Traditional metrics, like the apnea-hypopnea index and oxygen saturation, often fail to capture the full physiological stress of sleep apnea. A study, which serves as a direct surrogate for respiratory effort during sleep, could predict long-term mortality. Analyzing over 16,000 patients with suspected sleep apnea over a median 15-year follow-up period, researchers found that patients in the third and fourth quartiles of median esophageal pressure had a significantly increased risk of death. Even after adjusting for age, sex, body mass index, comorbidities, apnea-hypopnea index, and mean oxygen saturation, a higher median esophageal pressure remained independently associated with mortality, with the third quartile showing a 21% increase in risk. This indicates that measuring respiratory effort provides vital prognostic information that goes beyond traditional sleep metrics. In a similar effort to improve risk prediction in infectious pulmonary diseases, a multi-center retrospective cohort study. Among 538 patients, 40% experienced disease recurrence. By analyzing chest-computed tomography scans before and after treatment, the researchers discovered that a higher post-treatment cellular bronchiolitis score was independently associated with recurrence, with an adjusted hazard ratio of 1.64. Specifically, a post-treatment cellular bronchiolitis score of 3 or higher was associated with an increased risk of recurrence across both the nodular bronchiectatic and fibrocavitary phenotypes, suggesting that residual cellular bronchiolitis on post-treatment imaging is a powerful radiological marker to identify patients who require closer surveillance. Meanwhile, therapeutic strategies for chronic inflammatory airway diseases are shifting focus. A review in Respiratory Medicine explores the therapeutic landscape of targeting the neutrophil, dipeptidyl peptidase 1, or DPP1, protease axis in bronchiectasis, chronic obstructive pulmonary disease, and asthma. While downstream interventions like selective neutrophil elastase inhibitors have largely failed due to inflammatory redundancy, upstream inhibition of DPP1 during bone marrow maturation has emerged as a promising strategy. DPP1 inhibitors reduce the protease load of circulating neutrophils without broadly suppressing innate immunity. This approach has already shown clinically meaningful reductions in bronchiectasis exacerbations and airway protease activity, and it offers a biologically compelling path forward for neutrophil-predominant chronic obstructive pulmonary disease phenotypes. Finally, we look at lung cancer screening, where racial and ethnic disparities in eligibility and outcomes remain a critical concern. A large cohort study, utilizing data from over 641,000 participants in the lung cancer cohort consortium, The investigators found that 11 of the 16 models substantially underestimated lung cancer risk in non-Hispanic Black participants, showing an expected to observed ratio of less than 0.75. Furthermore, 13 of the 16 models demonstrated lower discrimination in Asian participants compared to other groups, and 15 models showed lower discrimination in non-Hispanic Black than in non-Hispanic white participants. When the researchers applied risk-based strategies to select a screening population equivalent in size to that defined by the United States Preventive Services Task Force 2021 criteria, the risk-based approaches achieved better average screening efficiency and reduced racial and ethnic disparities in efficiency. Specifically, the prostate, lung, colorectal, and ovarian cancer screening trial model 2012 and the life years gained from screening computed tomography model performed best. However, the authors emphasized that no single strategy was able to simultaneously optimize eligibility, sensitivity, and efficiency, while also eliminating racial and ethnic differences, highlighting the urgent need to further refine and optimize these prediction models for the diverse population of the United States. If you only have time for one paper this week, make it the official American Thoracic Society Clinical Practice Guideline on non-invasive respiratory support. This comprehensive document offers highly practical, evidence-based recommendations for high-flow nasal cannula, non-invasive ventilation, and continuous positive airway pressure across the entire spectrum of acute respiratory failure, providing a clear roadmap for bedside clinicians to optimize patient outcomes and reduce intensive care unit utilization. Here are the key takeaways from this week in pulmonary. First, for acute hypoxemic respiratory failure, prioritize high-flow nasal cannula while reserving non-invasive ventilation for hypercapnic respiratory failure and high-risk post-extubation patients. Second, respiratory effort during sleep, measured by negative esophageal pressure, is a strong, independent predictor of long-term all-cause mortality, offering prognostic value that extends beyond the traditional apnea-hypopnea index. Third, a post-treatment chest computed tomography scan, showing a cellular bronchiolitis score of 3 or higher, is a key radiological predictor of recurrence in patients with successfully treated Mycobacterium avium complex pulmonary disease. Finally, current lung cancer risk prediction models in the United States systematically underestimate risk in non-Hispanic Black patients and have lower discrimination in Asian cohorts, underscoring the need for more equitable and precise screening tools. That's your roundup for this week in pulmonary. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary for clinical decisions. Always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.